Hey guys, we're going to go ahead and get started. I'm Denise Renner. We're going to do this next session on storms versus seizures. So Dr. Keith Coffman is the director of Movement Disorders Program and the director of the Tourette Syndrome Centers of Excellence at Children's Mercy Hospital in Kansas City. He'll be speaking about I know I'm going to get this wrong. PSH, Paroxysmal Sympathetic Hyperactivity, and why it's been so overlooked and as a symptom of genetic neurological disease. Along with PSH, he's helped many families better understand dysautonomia and neurostorms and the medications used for these symptoms. Please help me in welcoming Dr. Keith Coffman.
Okay. Which button? That's the button. Okay. So I'm a pacer. Okay. So I don't stand still when I talk. So a bunch of disclosures. So number one, I have no financial relationships to disclose because I'm an academic child neurologist. Next disclosure, I am not a molecular or genetic GRICon disorder expert. I'm a movement disorder doc, and my scientific background is in systems neuroscience, so how things operate at a more macro level. So therefore, I'm a lumper and not a splitter. You're not going to hear me talk about mutations and channels and things of that nature. That's not how my brain works. I was trained to think about how symptoms and problems are related to each other. So movement disorders neurology is about recognizing patterns of abnormal movements and the patterns of symptoms that occur with these abnormal movements. So we're going to talk about the autonomic nervous system. So the autonomic nervous system is responsible for the automatic functions of the human, right? So everything you see here, heart rate, temperature, motility of the intestines, bowel and bladder control, and I separate intestinal motility from bowel and bladder on purpose. Sweating, arousal, so how awake and alert you are, as well as your sleep-wake cycles and your response to pain, right? Oh, so the three branches of the autonomic nervous system are the enteric nervous system, basically your gut, from your esophagus all the way down to your rectum. Your sympathetic nervous system, which is your fight, flight, or freeze system. And then your parasympathetic nervous system, your rest and digest phase, okay? So this is the autonomic nervous system in pictorial form. And as you see on the left, the cool color, the parasympathetic system, right? It's how you chill, it's how you relax, it's how you stay calm, right? Your sympathetic nervous system gets you jazzed up, gets you amped up, okay? And the box is the enteric nervous system, so your intestinal tract, right? So everybody talks about the gut-brain connection, things of that nature. Well, we're going to talk about the fact that the brain regions that regulate autonomic output. So one of the biggest areas is the hypothalamus. So control central for autonomic control. Hunger and thirst, sleep-wake cycles, temperature, blood pressure, blood vessel tone, pain response, sweating, drooling, hormone release. The hypothalamus, small structure deep in the center of the brain that has a bunch of different nuclei that each of which has different functions related to these, okay? The substantia nigra, one of my favorite regions of the brain because that's where dopamine lives. Dopamine makes you move. Dopamine's involved in reward. Dopamine helps your intestines work. And then heart rate, blood pressure, blood vessel tone. The serotonin nuclei are the raphe. They're deep in the brainstem, and they're involved in mood, pain, vomiting, and blood vessel tone. And then your medulla, deep at the base of the brainstem, heart rate, breathing, sneezing, and also vomiting, right? So what happens when the balance gets disrupted? What happens whenever you have too much autonomic activity from one part of the system versus the other? So the paper that I'm going to talk about here was Autonomic Dysfunction in Developmental and Epileptic Encephalopathies. So this is work that I was privileged to do with Ann Berg and Deb Gabler-Spira. And we had a cohort of 300 children who had different developmental and epileptic encephalopathies, and really looked at how common by parent report are autonomic symptoms. So there was a parental survey of autonomic symptoms in 6 different functional domains. So cardiac, respiratory, sweating, temperature control, GI, and other. And others, things like sleep-wake cycle disruption, or unusual flushing, or unexplained swelling, things of that nature. 81% of the subjects in the cohort had self-reported symptoms, an impairment of one functional domain. So these autonomic symptoms causing negative impact on quality of life. 90% of the 313 patients involved in this study, the autonomic dysfunction caused problems in day-to-day life. So what happens when the balance gets severely disrupted? So what happens whenever you have a flood one way or the other? So we're going to talk about what happens when your sympathetic nervous system flies out of control. Okay, so PSH, Paroxysmal Sympathetic Hyperactivity. This is now the official term. This entity has gone by tons and tons of names throughout the medical literature, but PSH has been the official term since 2014, and there are now in adults with brain injury official diagnostic criteria. So it's only ever been actually studied in adult patients with severe acute brain injury. There has not been anyone who's looked to see, does this occur in patients with neurogenetic conditions? The first paper that we published, Dr. Berg, Spira, and I, was the first ever paper to say, hey, this is a big problem in the DEE community. We need to study it more. Okay. So the diagnostic criteria came out of the journal Neurotrauma in 2014. And the biggest problem with the criteria is it has to be, to get PSH, you have to have a documented acute brain injury. So there's a great deal of work to be done in terms of making this entity able to be officially recognized and diagnosed in patients like kids with GRI disorders and other DEEs who don't have an acute brain injury. So what is PSH? Okay, so PSH is a sudden onset of increase in temperature, heart rate, respiratory rate, flushing, sweating, drooling, often with abnormal posturing called dystonia. It's very commonly mistaken for seizure. Episodes can last minutes to hours. They're absolutely exhausting. They can be quite painful, and they don't respond to medications to stop seizures. Okay. The key thing, everybody, and show of hands who's had episodes like this and get EEG, and it's like, well, it's not seizure. And after it's not seizure, good luck with that. Who's hurt? Yeah, that's why I'm here. Okay. So what do these look like? Okay, so the little girl on the left is the same little girl as the second picture. So this is a mild event for her. You can see she's getting a little bit dystonic, right? So the thing about movement disorders neurology is its phenomenology, right? So if you look at her feet, that's not the normal position of the human foot, right? Your ankle should be at neutral. It shouldn't be extended. Your toes should not be curled down. And then you can see, play that again. Okay, can we get sound? So this is a severe episode. That is not a normal cry, right? And if you look at her color, that is not a normal color of a human, right? So she used to have events so severe that she actually ended up fracturing her femur from these events. Okay, and that's how I met her. Okay, little guy in, can we go back and start the third video? Okay, little guy on the third picture. So you can see his face, right? His face is very red. And you can see that he has incredibly unusual posturing as well. He has dystonia to the point of what's called epistoponus. So neck extended, back extended. And you can see in the last video here, right? Just think about trying to put yourself in that position, right? Just even trying to put yourself in that position is not possible. So when people who have this, who's been told, well, these are behavioral, right? This isn't, no human behaves this way, okay? This is not a voluntary posture. This is completely involuntary, and it's called dystonia, okay? So when it comes to PSH, you have to prevent it from happening once you identify what it is, okay? So one of the biggest things we talk about in the world of PSH is finding triggers, okay? So you saw those little kids, they're red, they're hot. Cooler temperature rather than warmer, okay? Turn down the lights, lower the noise, work to regulate sleep-wake cycles, right? Funny, Dr. Coffman. Regulate sleep-wake cycle in a kid with a neurogenetic disorder. We're gonna talk about that, okay? No, that we're gonna talk about that, okay? Work to regulate bowel and bladder control. Yeah, again, sure, we're gonna do that in a kid who's got motor control issues and developmental epilepsy, right? And then evaluate for pain generators, okay? So pain generators in kids who don't have verbal abilities require detective skills, okay? You have to think about unusual causes of pain, right? Just changes in position, right? So one of the biggest things I ask about whenever I see folks who have this is, does it change when you change position? Is there a position that you can put them in where these happen less? Is there a position that you put them in wherever it happens all the time, okay? The old adage, doc, it hurts when I do this. Well, don't do that anymore, right? If you figured out that you can make these things happen by doing certain things, try to avoid those certain things as possible. Okay. So when we think about treating PSH, we have to decrease the output of the autonomic nervous system, okay? So when I talk about families with PSH and try to stop events once they've started, you're not going to be able to stop these in the moment as they're happening. You have to prevent them from happening, okay? One of the curious things about most people with PSH, well, it's curious until you think about it, is that for most people, they tend to have a certain time of day when they occur. And we'll talk about why that's the case and what the neuroanatomy is behind that. There's little data in the medical literature about what's truly effective, okay? The research that's been done has been basically convenient samples of acutely hospitalized patients, both pediatric and adult, with brain injury. So we have to use medications that decrease autonomic outputs. You have to use medications that work on dopamine or work on norepinephrine to keep those neurotransmitters from flooding the system and perpetuating this, okay? One of the things that I use frequently is the medication called clonidine, which is available in the United States. It is a presynaptic alpha-2 agonist. So it works presynaptically to decrease the release of norepinephrine in brain, okay? When you talk about dopamine modulating medications, one of the things that's used in treating this is a medication called bromocriptine. Unfortunately, it has tons of negative side effects and it shouldn't be used long-term, so we don't use a whole lot of that. So we use medications that treat pain, because often these are precipitated by pain. And whenever we treat pain in children and young adults and teenagers, we use non-opioid agents. So problem with the adult literature when talking about PSH is they really love morphine to treat this problem. We don't do that in kid medicine, right? We don't say, here's your prescription for morphine for your 2-year-old. We're gonna be on this for the rest of forever. So we have to use creative medications. And then we have to treat the underlying dystonia. So one of the biggest things that has happened over the course of the last decade since I've gotten involved in taking care of kids with PSH and DEEs is a lot of the patients who have come to see me or have sent me videos, before the episodes even start, I watch the videos and I see that actually they're having dystonia and then the PSH starts. And dystonia is one of the most under-recognized neurologic conditions in the world of movement disorders neurology, especially in kids, because kid brains are still growing, still developing. Their nervous systems are immature. So their patterns of movement are not what classically trained neurologists think of as patterns of movement that are that make sense to them. You have to think about, in a younger nervous system, a more immature nervous system, is that a movement that would be a normal movement or an abnormal movement? Okay. So as I was thinking about this, not being a molecular person, not being a genetics person, had to think to myself, why would kids with GRICon disorders have PSH episodes? Why in the brain would this occur? And then Dr. Frankel mentioned yesterday, it's not always the channel that causes the problem. You have to think downstream from the channel to see what may be going on. And that made a ton of sense to me. And then when Michael was talking earlier about the issues that they had with Fragile X and clinical trials and trying to figure out where was the disease, where was the pathology, was it the gene itself or was it other parts of the brain? Thankfully, the talk had already been written by that point, but I was like, yeah, that's exactly where the problem lives. Okay, so I went to the literature and said, okay, if you mess with glutamate receptors, what happens? What kind of functions happen abnormally when you mess with glutamate receptors? So I thought, PSH comes from the hypothalamus. This is well known. Is PSH in GRICon disorders, is this a direct result of hypothalamic dysfunction? So I started looking and looked at glutamate receptors and hypothalamus function. And lo and behold, if you look at NMDA receptors in the lateral hypothalamus, big pain center there, they actually create erosions in the gut under cold water restraint, which is a stress paradigm, okay? So then, if you look at different subtypes of the NMDA receptors are involved in sustaining sympathetic vasomotor activity and hypertension, right? So they contribute to high blood pressure. And then if you look at AMPA receptors, you actually increase excitability in the hypothalamus and sympathetic drive and hypertension. It's like, wow, you mess with glutamate receptors and you get all kinds of hypothalamic dysfunction. This makes a whole lot of sense in GRICon patients. And then I thought about the sleep piece, because one of the things that people will talk about with PSH episodes is they'll sometimes not sleep for days and days and days when it's going on. And we know that sleep disorders are a big part of the GRI phenotype, regardless of what your mutation is. So then I'm like, okay, what happens if you mess with glutamate receptors in sleep? So NMDA receptors in the lateral preoptic hypothalamus are essential for actually sustaining your REM and non-REM sleep patterns, right? And then if you look at glutamate, it actually blocks serotonin and messes with circadian pacemakers through both your AMPA and NMDA receptors. So there's a big reason that sleep dysfunction may be going on. So I thought, here's a great opportunity, right? So what's the neurophysiology of the hypothalamus in GRI mice, right? And what's the neuroanatomy of the hypothalamus in GRI mice and GRI patients? So if you look at the baseline hypothalamic function in your rodent models, your wild types, and then you do your knockouts, which is science beyond stuff that I ever thought about. How does the hypothalamic function change? How does the hypothalamic anatomy change? And is this, as we talked about earlier, is this a primary problem when you mess with glutamate receptors? Or is it a downstream consequence that Michael talked about and something that you have to be aware of, because you can do everything you want to the channel, but if you're messing with anatomy downstream, you're not going to get better. So as a movement disorder doc and as a systems neuroscience person, I have to always think about, does that system explain everything? No, that system does not explain everything at all. I can't connect hypotonia, movement disorder, intellectual disability, developmental delay, autism, or epilepsy to the hypothalamus, right? There are some rare forms of hypothalamic seizures called gelastic seizures, but they're not that fun to talk about. Pun intended, because gelastic seizures is seizures that are characterized by laughing, okay? So is there a downstream effect of NMDA receptor dysfunction in GRI patients that cause this phenomenon? I'm a neurotransmitter guy, right? Is there neurotransmitter dysfunction? So this is unabashedly stolen from the GRI website, and it talks about the different symptoms, okay? So hypotonia, GI issues, PSH, autism, sleep disorders, dystonia. And as I was looking through this, after Keith asked me to do this talk, my pattern recognition software started kicking in. And I'm like, I've seen this. This is not a new phenomenon. What does this look like? Okay. So symptoms of disorders of biogenic amine metabolism. Okay, what the heck is that? Neurotransmitters, dopamine, serotonin, epinephrine, norepinephrine. Okay, so if you don't make neurotransmitters properly, you get hypotonia, you get epilepsy, you have dysautonomia, you have GI dysfunction, you have movement disorders, you have oculogyrate crisis. And this was actually Tim Benke's paper from 2021, where he talked about the different movement phenomenon that are seen in the GRIN family of disorders. Tim talked about the rate of oculogyrate crisis. And that's actually one of the big things that tipped me off, because you only get oculogyrate crisis when you mess with dopamine, okay? You don't get oculogyrate crisis unless you mess with any other neurotransmitter. You only get it when you mess with dopamine. Sleep disturbance, irritability, and intellectual disability and developmental delay. So these symptoms are well known to occur in patients who don't make neurotransmitters properly. And this is not my work. This is work from the amazing polymath, Phil Pearl and his collaborators. Phil is a brilliant child neurologist who's published on neurotransmitter disorders and epilepsy, and he's also a classically trained musician and a phenomenal pianist. I don't know when he ever sleeps, given everything he does. Okay, but we know, right? So if we can go back one slide. Back one slide, please. Okay, so there's GRI. There's neurotransmitters. It's the same set of symptoms. Okay, we have to look at neurotransmitters in these conditions. So what does dopamine do? Motor control, attention, focus, learning. Norepinephrine wakes you up, fight or flight, autonomic control. Epinephrine, fight or flight, blood glucose control, pupil dilatation. And then serotonin, mood, thinking, learning, pain, memory, nausea, appetite, sleep. Okay, did I miss anything? So why might GRI disorders represent or resemble neurotransmitter disorders? Okay, so every time I see a patient who comes to me with a movement disorder, this picture comes to my brain. Okay, this is the neurology that I deal with every day. This is the basal ganglia. These are the basal ganglia, excuse me. Very simple circuit, right? Cortex. No, it is. Compared to epilepsy, this is very simple neurology. It's why it works for me. Okay. From the cortex through glutamate, you activate your basal ganglia that are in blue. Okay. Your basal ganglia mostly work through GABA and then back to the cortex. Okay. So in movement disorders neurology, we know if you mess with certain neurotransmitters, you get a bunch of symptoms. So if you knock out dopamine, you get Parkinson, right? Parkinson patients have abnormal movements. They also have tons of autonomic symptoms, right? They have autonomic symptoms that are often worse than their movement disorder symptoms. If you knock out the indirect pathway in the basal ganglia, you get the movement disorder you get is chorea, and the clinical disease you get is Huntington. Okay, so that one spot there, you get Huntington. All the neuropsychiatric symptoms in the world, tons of movement disorder symptoms, and as the disease progresses, you get autonomic symptoms. Okay. Now, if you mess with GABA, right? So there are diseases that you don't make or metabolize GABA properly. And when you don't metabolize GABA properly, you get a condition called SSADH deficiency, which is another neurotransmitter disorder. These kids have hypotonia, epilepsy, movement disorder, autonomic dysfunction, okay? So what needs to be done, I'm not the guy to do it. It's not the neurology I do, it's not the science that I do. But to understand the full phenomenology, the full patient experience, the full phenotype, what in the world happens when you alter glutamate activity from the cortex to the basal ganglia and then from the thalamus back to the cortex? What happens in the basal ganglia, right? What happens to dopamine? What happens to serotonin, epinephrine, and norepinephrine? So it's a huge opportunity to try to get a better understanding of the full phenotype of GRI disorders. What's the neurophysiology of the basal ganglia in the GRI mice? Okay. What do their patterns of movement look like compared to wild type? How is their locomotion? Hypotonia is hypotonia, right? As a movement disorder neurologist, hypotonia is a symptom. It is a finding. It is not something that I can say, I know why you have hypotonia, right? Anytime you disrupt the brain, you're going to get hypotonia. Do I have dystonia? Do I have chorea? Do I have any other involuntary movement disorder? What's the neuroanatomy of the basal ganglia in GRI mice and GRI patients? There are some reports of some dysplastic basal ganglia in some of the mutations. But here's a huge opportunity to better understand what's really going on. And I don't know if you can do this in mice. I am not a mouse person. When I see a human who comes to me with a movement disorder problem and has a clinical course like I described, I can get spinal fluid, send it to Dr. Keith Hyland, who has described most of these neurotransmitter disorders, and Keith can tell me if the neurotransmitter metabolites are normal or abnormal in those patients. And based on what Keith tells me, I know what to treat with. I don't know if you can do neurotransmitter analysis in mice, right? But it's a great thought. Okay, so I hope I've convinced everyone in here who's not a parent or a family member living with a child with a GRI disorder that autonomic dysfunction is part of the GRI phenotype. The potential contribution of the hypothalamus is an area for exploration. And the potential contribution of altered downstream neurotransmitter disruption is an area for exploration. Thank you. And that's where I get to work. Okay.
We're going to go ahead and break for lunch now. I know we have an hour session Q&A after lunch. So instead of taking some questions now and then breaking, we'll go ahead and break early and reconvene at, is it 1 o'clock? 1 hour? 1 o'clock for Q&A with Dr. Coffman. Thank you.